Pete, while we're waiting, we might let Mary Ellen give a few remarks about her January presentation, which is online for anybody that wants to view it.
I think it's my audio.
Marlene, I'm going to have to tell you what, we're going to, we can barely hear you. So I think you'll be listening only for now. Raise your hand if you have something to say, and we'll make sure we'll do our best. Maybe you'll connect better. Mary Ellen, if you have a few minutes, you want to talk about something, you got about 3 minutes. Otherwise, we can fill you in. We can pop you in later.
Okay.
What did you want, Tim?
Why don't you ask a couple of key questions?
Go ahead. Do you have a question? Lynn, did you have a question?
Oh, I didn't really have a question. Does anybody else have a specific question they'd like to ask Mary Ellen, or she could just give us a quick synopsis of how long she waited, how she's doing now? How about we just do that?
Yeah.
How long did you suffer, Mary Ellen, with
My procedure was in October, but I got real bad, probably for about a month prior to the procedure. Maybe 6 weeks. And then we scheduled it. I had to wait about 2 weeks for the procedure, and then went in and then got immediate relief that day. As I told you.
Had you had other procedures prior to this?
I had an MVD about 8 years prior to it. That was very effective, but it did not last more than about 3 years. So I was back on the medication.
So you're a long-time sufferer of TN, though. You've had this for
about 25 years.
25 years, like Lynn.
Me too.
Yeah,
Okay.
And this Grace as well. So the MVD gave you short-term relief. So far, the rhizotomy has been very successful.
Very successful. Yes.
That's very promising.
And Dr. Malik said, you just don't know how long it will last. He had said anywhere from 3 months to years. It's just different with everybody. So as I said to Lynn when we first got on, I said every day I wake up kind of feeling and thinking, is today going to be the day? Unfortunately, you live like that, but it isn't today.
What year, when did you have the rhizotomy?
In October, just this past October.
Because I had it in 2016 after my MVD failed. And I am here to say I'm still pain-free.
Oh, that's wonderful, Grace.
TN is forever, and so we need to be prepared. But so far, so good. 2016.
Wonderful to hear, Grace.
Yes, 6 years and counting.
Yeah.
Who did yours, Grace?
Ken Casey.
Oh, okay. And he's looking for a living donor,
I know, but I'm over the age.
Yeah, I know most of us are, but we all have kids and friends, and we're rattling every door we can.
Yeah.
Last question, Mary Ellen, before Dr. Malik begins. If there's always reasons we don't do things. I put off a few surgeries in my life, and there's reasons that I did that I wish I hadn't done looking backwards. So what is there items something that you were afraid of would happen that didn't happen that you'd like to share that maybe stopping other people from getting a rhizotomy?
Well, they do say that there is a chance that he said there's a 3% chance that it could make it worse. There's a 70% chance that it could get better. But I was in the position that I was so bad that I had to do it.
Right.
I didn't even consider that 3% chance. Of course, it enters anybody's mind. You'd be foolish if it didn't. But I had to do it. I knew I needed to do something. So I just kind of tossed aside that 3% chance and had to be positive and think that it's going to work, and it did. So
fantastic. Well done.
Yeah.
So Dr. Malik, the floor is yours.
Can you see the screen?
Yes.
Yes.
Very good.
I just lost a bunch of people.
Yeah, that's how that goes.
Normal. Yeah.
Yeah, you can. There's a gallery. The gallery view has got the 9 dots. But you're going to lose.
You can press that lower arrow if you want to see the other people also, without giving up your screen share.
That's okay. So I just thought that in addition to our general discussion, it may be worthwhile to give you a little bit technical information too. I don't know whether you are up to it or not. Can you hear me all right?
I can hear you.
Yes.
Okay. So, you know, you are quite familiar with these statements. TN1 or typical trigeminal neuralgia, general onset is after the age of 40. It is more frequent in females and more frequent on the right side. We don't know for sure why. We do know that the lower part of the face is more affected. And, you know, we have 3 divisions of the trigeminal nerve, which are labeled as V1, V2, V3. The other technical names for those are, the first division is ophthalmic, related to the eye. The second division is maxillary, related to the cheek. And the third one is mandibular, related to the lower jaw. So generally, the pain would spread from one division to the adjacent one, but it would rarely skip the division. And that, I think, has probably been part of the proof that compression over a period of time adds more to the changes in the nerve, and it's going to do it to the adjacent division rather than skip it. If we superimpose the distribution of the nerve, this is, the nerve is coming over here. This is what we refer to as ganglion or Ghauserian ganglion. The nerve fibers collect over here, and then it divides into 3 divisions. The first division right here, that's V1 or ophthalmic. It runs forward at the base of the skull and ultimately comes out from the top of the orbit, top of the eye, within the orbit, eye socket. It supplies sensation to the eye. It supplies sensation to the bridge of the nose, and it supplies sensation to the forehead. The second division, which is maxillary or V2, it comes out through the skull, through an opening we call foramen rotundum, that's below and behind the eye. It actually comes out below the eye, gives some branches, as you can see, over to the upper jaw, the teeth, the cheek, and this is the opening that we refer to as infraorbital foramen, which is below the eye. The third division comes down through the base of the skull, through an opening called foramen ovale, O-V-A-L-E, and this supplies branches to the jaw, to the teeth, to the anterior part of the tongue, and to the mandible. It also gives a branch that goes to the temple area and a bit portion higher up of the skull. Now, different procedures that we do, and I think Dr. Schwab is probably going to talk about most and some more. But the simplest thing that we can do, and I often do it, is local injections. Injection of absolute alcohol You can inject it here if the pain is in the forehead. This is what we refer to as supraorbital or supratrochlear opening. This is where the nerve goes up. You could inject at the infraorbital foramen for the pain in the cheek area and the side of the nose. You can actually go through foramen ovale and inject. And I personally don't do it, but I sometimes have the oral surgeons do it. There is an opening in the jaw. It's called mental foramen, and you can inject through that one too. This provides local relief. It's very effective actually. So if we do it for the infraorbital foramen, it would make this portion of the face numb. Do it up in the forehead, it would make the forehead numb. It often lasts some months, but generally less than 6 months. It's very suitable for people who are medically unstable. Somebody has had a heart attack or other medical condition, and they're really not suitable for other procedures. This can tide the person over for a period of time. So here on a skull, this would be the first division. That's supraorbital, infraorbital, going through foramen ovale, and the mental would be here. You can do the injections into the main divisions, that is at the foramen ovale for the mandibular division, also for the maxillary, into the ganglion, which sits in a pocket of bone that we refer to as Ghauserian ganglion, a Meckel's cave. You could inject phenol and glycerin, which we don't use these days, or you do the glycerol injections into the Meckel's cave, and we'll talk about just a little bit more. So glycerol injection is the pain relief with the less sensory changes compared to the radio frequency. And that's why this was popularized. Actually, Dr. Schwab uses this more often. But the procedure itself is relatively painful. There are high early failures. Compared to what was suggested earlier on, there are more sensory changes. You could get into these untoward feeling, which we call dysesthesias. And if glycerol spills into the space around the brain, you could potentially have changes with the other nerves. This was a procedure that was the most common procedure used before the microvascular decompression and the radiofrequency rhizotomy. This was known as Spiller-Fraser procedure. So before late 70s, this is what we were doing. And what you would do is actually you go through the temple with an opening in front of the ear, going underneath the brain, underneath the lining of the brain, back to the area of the nerve. And then you would depend upon the fibers that are here. They are going to the third division. The middle ones are going to the second division. Generally, the first division we do not like to damage, and it's farther deeper in, so it was feasible to do this. And on a model, you can see this is the base of the skull. It is depicting these nerves. So this is the trigeminal nerve coming from close to the brainstem over here. It crosses over into the temple area and it's underneath the lining of the skull, or the dura as we call it. This is the Ghauserian ganglion. It sits in the Meckel's cave. Here it's shown to have taken off the lining or the dura. So then you can see the nerve here, which is coming from the back here. It comes, makes this ganglion. This is the third division that goes out through this foramen called foramen ovale. This is the second division that goes out through foramen rotundum. And this is the first division that comes out behind the eye. So if we go to the sectioning was done, you will come underneath here, underneath the brain, and cut these fibers. If we do it behind the ear, what we call posterior fossa, then you will come through here, or on this side here, and get to the nerve at this point, which is similar spot that we do MVD. The other adjacent nerves, right over here is the nerve for hearing and the nerve for facial movements. Down here are the nerves for swallowing and so forth, and here one moving the tongue. Now you could cut the nerve in the posterior fossa, which was popularized by Dr. Dandy back in 1920s. Most people were scared to actually go back in that area, but he is the one who actually made the observations of blood vessels, loops around the nerve. This got picked up later on. This is mostly, I would use it occasionally. It's mostly used for failed treatment with all other procedures, and if the person is willing to accept numbness of the face, because this will result in numbness. This is also a procedure of choice in patients with multiple sclerosis when the peripheral procedures are not successful. And this happens maybe once a year or so that I would do that. Balloon compression procedures. Initially, these were done openly, where you would expose the nerve and compress it. Now, the balloon compression is used, just like these other needle procedures. You go through the foramen ovale into the Meckel's cave. There is concern about injury to the blood vessels or the cranial nerves, other nerves. Most of the nerves are going around the eye, run in that area. I personally have not done this procedure, although it is very much favored by some people. This is what we are supposed to talk about mostly. Trigeminal neuralgia, percutaneous radiofrequency, thermocoagulation, or rhizotomy. Rhizotomy means cutting the nerve root. This is not cutting, but it's heating up the nerve. This is the most frequent procedure under local anesthesia. The patient is on the side, on the back. These are 3 points. This is about an inch away from the angle of the mouth. This is about 1.25 inches in front of the ear. And the third one is at the pupil. These are gross lines that gives us an idea as to how to direct the needle. Here is the X-ray equipment. And then this is the radio frequency generator. So you go with the needle through the foramen ovale. It gets back into this area. So here the needle comes along this third branch. Here you see the needle. And depending upon how far deep it is, you can treat the third division, you can treat the second division, and you can even treat the first division. This is not an absolute arrangement of the nerve fibers, and therefore, through the procedure, we have to do some checking as to how much numbness a person is getting or on the stimulation where the sensation is coming through. On the X-ray, once we have the needle in place, we stimulate the nerve. And this is why it's done under initial local anesthesia and then IV anesthetic. The short-acting anesthetics, I use Bravitol. Sometimes people use Propofol. It lasts few minutes. That allows you to put the needle in while the person is sleeping, so it doesn't hurt. Once the needle is in place, we let the person wake up and then stimulate the nerve. It's done at a frequency where it doesn't cause pain, but it causes tingling sensation. And therefore, we have to ask the patient whether the tingling is in the lower jaw, is it in the cheek, is it in the forehead? And you adjust the needle based on where the tingling is happening and where the patient's pain is. Generally try to avoid the first division because unless the pain is in the first division, because you don't want to create the numbness of the eye. Otherwise, if you rub the eye, you may get corneal abrasions. If we look at the same picture that I showed you before, without showing the nerve, so this is the Meckel's cave. This is what we refer to as middle fossa. This is the posterior fossa. This is the foramen ovale. So you're going through the cheek between the upper and the lower jaw. It's a small space, so it sometimes requires a fair amount of effort and poking to get into the right place. If we look from the base up, so here is the foramen ovale. So you are right at the base of the skull and you go through this opening. And in a more magnified view, you can again see here is the foramen ovale. There is another small foramen that has a blood vessel in it. So the needle goes through here. So what are the limitations? First of all, it is inability to actually get into the foramen. And that happens maybe 5% of the time in my hands. So then you can do this procedure. We sometimes can use a CT scan and intraoperative navigation to get into the foramen. The localization is imprecise, even though we try to get as best as we can. Sometimes the patients are very accurate, and sometimes they are not, depending upon their general medical status. Sometimes the medication makes them a little bit more groggy, and they're not able to, so we have to rely more from the position of the needle. It can be repeated. I think one of the benefits of this procedure is that you can repeat it. It's an outpatient procedure. We do it in the operating room. Patient is observed for a couple of hours and patient goes home. But if you do repeated procedures, there is a decreasing benefit of it. Question of anesthesia dolorosa, which is painful numbness. About 8 to 10% of the patients everybody gets some degree of numbness, sometimes more and sometimes less. Generally, the more the numbness, the longer is the pain relief. But the more is the numbness, there is more chance of patient feeling discomfort of numbness. Even though the face is numb, you stick with the needle, you can't feel it. You touch it, you can feel it, like phantom pain from amputation. People have this pain which is difficult to treat. The third division, in addition to sensation of the lower jaw, also has one branch, which is actually a separate branch, very recognizable if we look at the nerve, that supplies motor fibers of chewing, movement of the jaw. So if we are particularly treating the third division, at least there is some temporary weakness of the jaw muscle. The jaw would tend to deviate onto that side because these muscles push the jaw forward. If that is weaker, it would tend to deviate. But the motor nerves are actually far more stronger, and that tends to improve over a period of time. So it's not a long-term issue, but earlier on, there may be some weakness. It is not suitable if the pain is on both sides, especially if there is numbness with it, because if the face gets numb on both sides, you cannot feel the food and you can't eat well. So this is more suitable for doing one-sided procedure. What are the complications? Extremely rare. There may be some bleeding from the blood vessels at the base of the skull, generally without any consequences. There may be increase in blood pressure when the nerve is being heated up. Infection has been reported. I have not had anybody having that infection. And occasionally, this is a few percentage, because of the heat, you may notice double vision affecting the eye movement nerves. Again, that is a temporary phenomenon. What about the decompression procedures? So microvascular decompression, or MVD, obviously based on the observation of compression of the trigeminal nerve at the entry of the nerve into the brainstem. Initial observation, as I said, made by Dr. Dandy in the 1920s, and then it got popularized by Dr. Janetta in the 70s. Here, if we look at the MRI, these dark lines, these are blood vessels. So if the blood vessels are near the nerve, they are far more suitable. Although I personally don't use the findings from the MRI as a reason to do MVD. Because many of those blood vessels are normally supposed to be there. And the only way you can actually decide if the blood vessel was causing compression or there was a kink in the vessel is by looking at it. So if the pain is like TN1 and one comes to a stage where there is need for a surgical procedure and we decide to consider MVD, whether the MRI shows blood vessel changes or not, I would go ahead and explore the nerve. So this is an ideal procedure for relief of pain and preservation of sensation because it's addressing the cause of pain rather than just the symptoms. All other procedures that we refer to as ablative procedures, they are based on causing certain amount of damage to the nerve in order to cut back the sensation that the nerve carries. So here is the nerve. So this is a typical vascular compression. So when we first, the same patient, when we first looked at it, here was the nerve, here was the blood vessel, but we couldn't see the rest of the blood vessel. As we started working on the blood vessel, here you can see the blood vessel has a curve and it was underneath that nerve. Here you can see the blood vessel being pushed out. Here we totally pulled out from underneath the nerve. Nerve is back over here. And this is the loop of blood vessel that actually was underneath the nerve. And this is shredded Teflon that is placed between the blood vessel, two branches. The nerve is underneath there, and that's the procedure. Different sources of compression. You could have veins. Sometimes there's bony overgrowth that actually narrows the space. And I think somewhere along the way we had shown you a video on one of our patients where the young person, we had to drill that bone. Here is another blood vessel right here. You can actually see indentation into the nerve and the brainstem. Here you have basically the veins. The younger patients have more venous compression than arterial. As we grow up in age, the blood vessels become stiffer, and therefore the arteries tend to cause more compression. The benefits of, you have heard this many times before, of MVD are preservation of sensation. Now some patients do get some numbness from working around the nerve, but the aim is not to create numbness. It's treating the cause of the pain, and it has better long-term results. Limitations are age. You know, earlier on when we started doing it back in around 80, 81, we were limiting it to patients 70 and under. But as the time has gone by, I have treated patients in their 80s with good results. Since the hearing nerve is nearby, you worry about causing hearing deficit. It's extremely rare, at least in our experience. It's not an outpatient procedure. You have to be in the hospital 2 to 3 days, sometimes a little bit longer. There is always a risk of injury to the surrounding brain tissues. And one of the things that we worry about is the bone over the mastoid behind the ear. That's where the drilling happens. It has spaces in it, which we seal off, but sometimes the fluid can get in there and might come out of the nose, and that delays Again, it's a treatable problem. We often have to just put a catheter into the lower back and let the fluid drain for a few days, and that seals off by itself.
Yeah, I did not.
It's rarely you have to open it up and seal it. Outcome, more than 90% initial success, and this is off medication. About 70 to 75% remain pain-free at 20-year follow-up. About 10 to 15% have mild recurrences that could control with, again, with medication. And about 10 to 15% have severe recurrences that require other procedures like radiosurgery, radiofrequency, even stimulation procedures. The gamma knife radiosurgery. So here is the nerve on the MRI. Here's the brainstem. The nerve comes from here and goes into the middle fossa. So the exposure is off the nerve of the size of 4 millimeters, which is 1/6 of an inch. Very focal radiation. Single dose, stereotactically directed. About 70 to most commonly about 80, but some people use 70 to 90 gray, as we call it. These are the units of radiation to the trigeminal nerve. Benefits, it's a minimally invasive procedure. It's an outpatient procedure. There is no real surgery involved. There is no opening of the head. Patients go home. No limitations really to medical condition unless the person is just, somebody told me, I just don't want to go into that machine because your head is fixed into the gamma knife. It can be used in previously treated patients and minimal neurological risk. People can get numbness, but are exposure to the adjacent areas. Limitations, the effect is delayed 2 to 4 months. Although people have reported relief of pain on the same day, which is non-physiologic. A LINIAC-based radiosurgery is not quite as suitable, although the newer systems are really matching gamma knife. Risk of delayed nerve damage or radiation effect is always there, generally around 4 to 5%. And obviously it does not address the cause of the pain. Outcome, 60 to 70% with good to excellent results without or with medication. So in this group of patients, all of them are not off medication. That's how this result has been reported. Over 10% reported to have recurrence in 2 to 3 years. And if there is development of numbness, generally there is better pain control. Again, based on the same principle as we talked about. So in conclusion, as you know, the diagnosis of trigeminal neuralgia is solely based on history. So it requires diligent inquiry to establish the diagnosis. The treatment primarily is medical. The surgical treatment with most favorable results is MVD. Gamma knife is used with increasing frequency. And surgical management needs to be individualized. You have to really look at each patient differently. Based on my own personal experience of over 45 years of surgically managing these patients, these are my preferences, or biases, whatever you would refer to. Surgical procedures are meant for medical failures. Peripheral nerve injections in medically debilitated individuals. I can do them in the clinic. Percutaneous radiofrequency thermocoagulation in older patients, in patients who have failed MVD, and the patients with multiple sclerosis, because they don't have vascular compression. MVD in medically stable and younger patients, especially the ones who have first division pain, because you do not want to create numbness in that division. Radiosurgery in patients absolutely reluctant to have surgery are in some recurrent cases, after MVD or other procedures. Jim has asked me several times about the questions as to how frequently we do these procedures. I'm not one to be giving lectures and doing a lot of reporting and so forth. So I decided I'll look at 2021. We did 16 MVDs and 7 radiofrequency trigeminal rhizotomies, and maybe two or three radiosurgeries. That's what I had to say, and I think we are open for questions and discussion and debate, whatever.
Excellent. Thank you, Doctor.
Everybody can unmute if you'd like to. We had to mute so that the recording didn't pick up the background noise.
Oh, is that right?
There was a stray noise coming, so we muted everybody, so please unmute if you like. Or just raise your hand and we'll call on you. Whoever wants to speak. And remember, we can pause the recording at any time.
We could hear you, Doctor.
Okay, all
Yeah.
right.
Oh, Marcia has a question. You have to unmute, Marcia.
Go ahead.
I know it took me a second to get to it. I'm pretty
You're
good at
fine.
this. Okay. My question was on MD, whatever, it's micro,
Vascular
MDV.
decompression or MVD.
Yes. I've been, doing a lot of research on what my options were. And when I listened to the Facial Pain Association, different surgeons talking, one of the surgeons talked about how they're trying to avoid Teflon when they can, because there's problems with the Teflon getting loose and getting into the rest of your brain. I just guess I wanted your thoughts on that, because when I talked to a surgeon about possibly having that surgery, they talked about having Teflon.
The reason Teflon was picked up initially, the recommendation by Dr. Janetta was to use muscle, a piece of muscle between the nerve and the blood vessel. Muscle gets dissolved. Teflon does not get dissolved. It has the least amount of reaction. People still get some degree of scarring around it. Teflon does not go anywhere. It does not move at all.
Okay.
And it has no reaction, allergic or otherwise.
Thank you.
Roseanne has a question.
Hi. Thank you, doctor. What are some of the causes of a failed MVD? My husband had his in October and only had 3 weeks pain-free. So what would be some of the reasons for a failed MVD? And he's had pain ever since.
Part of it is dependent on what your findings were at the time of surgery. Some patients have major indentations into the nerve the vessels are very hard. Others may have the blood vessels running along the nerve and sometimes not touching the nerve. So we have few of those patients. Earlier on, I was counseling the patients that if we did not find a major blood vessel compression, we could partly or partially cut the nerve, which Dr. Dendy used to do. I think over a period of time, I gave up that idea because if you don't find a major blood vessel causing pressure, we can still do radiofrequency thermocoagulation. The other issue is that you may have pain related not to the blood vessel, but patients who have multiple sclerosis, they have exactly the same pain as regular trigeminal neuralgia. That's the reason we all do the MRIs, but we cannot always diagnose each and every condition. So maybe the reason for the pain is different. You may also have a situation where, we are looking at the nerve within the other nerves. Was there a blood vessel on the opposite side of the nerve from where you are approaching it, and that got missed? Uncommon, but that's possible. As I mentioned, in some patients, there is actually overgrowth of the bone under which the nerve goes from the back part of the head to the middle portion. And sometimes that might not get observed, and that requires the actually drilling of that bone so that the nerve has more room. Above all, I think there is nothing in the world that is 100%. And there are medically a lot of conditions that we don't necessarily understand. So, maybe there are a few people that even though we think it's the blood vessel that's causing the problem, that there is some other reason, whether they, over the centuries, different things have been implicated, vitamin deficiencies, viral infections, all kinds of things. So those are some of the reasons that the pain may come back.
I know with further discussion, and you said you always speak to the patients and discussing their history, and how then do you determine something like that? His surgeon seems to think that there's something else. My husband fell and banged and injured his face, that there's something else.
That's right. So we refer to that as neuropathic pain.
Yes.
Okay. And the neuropathic pain does not quite respond to, because it's being generated from the outside, because there was injury to the nerve. And so there, your ablative procedures probably have a better chance than microvascular decompression. Grace had a question.
Hello?
You have to unmute yourself. I thought Grace had a question.
Oh.
I don't know if I'm...
Joan, are you on? Are you talking?
Hi, I'm on, yes.
Okay.
Can I ask you, do you think difficult dental work has some things to do with it? Possibly?
Well, see, the issue always comes up about dental as to why the dental work was done. You know, there are some individuals who go to the dentist because the tooth was hurting. And the tooth was taken out, and many people actually lose several teeth along the way before the diagnosis gets made. On the other hand, if you're just having dental work done without any complaints, that is similar to having injury falling on the face and so forth, and that could be responsible for the neuropathic pain.
Thank you. I certainly am glad I had it done. Thank you very much, Dr. Malik.
You're most welcome.
We have a
Right.
question from
I'm
Al.
6 years out successfully.
Fantastic.
Go ahead, Alan.
I'm the outsider here. I'm the support group leader for Sacramento area. And I've had an MVD and I've been on meds and everything. Now, I went into remission about 12 or 15 years ago. And I'm still there, fortunately. And I don't know why I went into remission, number one. And number two, I take 5,000 micrograms of vitamin B12 sublingually. And I can't prove anything, but I believe it's keeping me in remission. Is there any more information on vitamin B12?
Well, it has been used, as I said, over the years. People have implicated viral infections, vitamin deficiencies. Vitamin B12 gets used for a lot of neurologic issues, neuropathies, and so forth. I don't know if we actually have a scientific evidence of its health. Now, this is a crazy disease. Remissions are not uncommon. That long a remission is uncommon, but patients may not have pain for 6 months, 3 months, a year, few years. And that's why even earlier on, we now believe that blood vessel compression is the reason for it. But people still argue the blood vessel is pulsating all the time, and why the pain comes on only periodically. Why not all the time? I don't think that we truly understand all the basics of why pain comes at a certain time, why those triggers that happen. There is work going on genetics of trigeminal neuralgia to see if there are any genetic factors. We are getting into this precision medicine, even in tumors. We're doing genetic labeling because same kind of a tumor behaves differently for different patients. And why is that the case? So there's a lot of work going on that basis. But honestly, we don't know. And vitamin B12 might be responsible. It's innocuous. Keep up on it.
Yeah.
Melody has a question.
Yes,
Yeah, Melody.
back to the dental procedures, numerous dental procedures causing the TN, which would probably be a TN2. You mentioned the injections. Does that help with TN2 or not? Is this all only TN1, typical TN?
Well, that would be actually third group. That's the TN2 is what we used to refer to as atypical trigeminal neuralgia. That meant that you had these paroxysms of pain but in between you also had some remaining pain most of the time, which was a little different pain, a dull ache or whatever. So there was a variation that those paroxysms were not present all the time. There was mixture of pain. That would be TN2. That's where this third term has come about as neuropathic pain. That's mean pain related to some kind of injury to the nerve. And yes, it is helped by some of those procedures, but that's where a fair amount of effort is going on motor cortex stimulation and other stimulation measures, even some peripheral stimulators that probably Dr. Shaw can shed some light on it next month. So if, let's say, the work was done in the upper jaw and the pain is there, you could have a stimulator placed peripherally that could help the pain.
Okay, thank you. Thank you.
Mary Ellen has the next question, followed by Roseanne.
Yeah, can you hear me or no?
Oh, sure, I can hear you.
Okay. This is what I hate dental work, but at the last meeting when I was speaking, I brought up that I was doing so well after you took care of me with the rhizotomy, but I do have to go to the dentist, and I have a bridge on my right side where you did the work for me. And I'm doing so well that I hesitate to go and have it looked at and have any work done if I need to. Would having any work done now, being that the nerve is still dead or whatever the term would be to refer to it, would that activate it? Or of course, like most of us are, I'm afraid to go while I'm doing well. Go to the dentist.
Obviously, none of us know that answer. Okay. But here is my simplistic answer. And that is, we do things based on necessity. If it is necessary to take care of it, you should go ahead and get it taken care of so that there is, no infection, nothing else happening that is going to cause you other difficulties. If it is not necessary, then hold off.
That's what I've been doing. Yeah, I don't think it is. It's just a routine. Like I said, when you have a bridge, you want to, make sure everything's okay.
Sure.
Okay. Thank you.
Roseanne, you had a question for Dr. Malik?
Yes. So after the failed MVD, and you're looking at other procedures like the rhizotomy or the balloon compression, how do you judge which is best for you? Because I too was on the facial pain conference and heard quite a bit. The more procedures you have, the less chance of success or continued success. So how do you go about deciding what's the best?
I would think that probably the better choice would be gamma knife radiosurgery. It's not invasive, and if it provides relief, you still have other things that you can do if the further recurrence happens. There's lesser chances of numbness. So to me, that would be probably the first recommendation.
I'm sorry, I didn't hear that. What can you repeat?
I said,
that?
Consider gamma knife radiosurgery.
It's the second option for failed MVD.
Correct. Or
did you hear that, Grace?
I did not. So can you repeat?
No problem. So Roseanne was advised by Dr. Malik that the next option should be gamma knife, in his opinion.
Oh, the gamma knife. Okay, all right. Not the rhizotomy.
Yeah, rhizotomy you could do anytime because with rhizotomy, you get some degree of numbness and sometimes very significant numbness. With gamma knife, that chance is low. So,
But the gamma knife, it lasts less long.
Well, it doesn't, but the radio frequency rhizotomy also has more recurrences compared to MVD. But the fact that this is an outpatient procedure, it can be repeated. Generally, the other procedures, gamma knife, people have done second gamma knife, but I personally don't think that has a major value. So if there is further recurrence, you could always use radiofrequency rhizotomy.
But I had the rhizotomy 6 years ago, and I'm still pain-free. Yes, I do have numbness on my face, but I would trade that any day for the pain.
Oh, that's great. Yeah.
So after a rhizotomy, can I have another one?
Sure.
Or could I have a gamma knife?
You could have either procedure, but preferably, I think since that gave you the best relief, that would be the procedure of choice.
Okay.
This is where I said we really need to individualize everyone.
Mm-hmm. Okay. Thank you.
Maria has a question, Dr. Malik.
Unmute yourself.
You need to unmute yourself, Maria.
I have a quick question for, as a follow-up for Grace. Did you find that you say you have facial numbness, but did it get better over time? Like slightly better? Was it more numb immediately and then?
You know, it's slightly better, but I have also become accustomed to it. So it really does not bother me.
Yeah, I think that's what's happened to me on my left side. Partly I'm accustomed to it, and partly it's improved. So.
That's true.
Yeah,
that's for everybody.
And you know, it doesn't bother my eating, my chewing. It's just kind of, I've acclimated to it.
Very good.
Okay.
So yeah.
Great. Debbie, might you have a question? You're newly diagnosed, I understand. Is there anything, I know Dr. Malik went through a lot of information, probably way too much that you didn't want to know exactly, but is there anything that we can help you with?
She had a question too.
Oh, did she? Okay, good.
Missed that.
Can it not be recorded?
Sure, absolutely.
Pausing recording. Roseanne has a question.
Thank you again. Doctor, how do you compare the balloon compression to the rhizotomy that you were just describing that Mary Ellen had?
I only have to rely on reports because I don't do that procedure. So I can't quite give you my own personal experience about it.
Other questions for Dr. Malik?
Mm-hmm.
Looks like New Zealand Lynn has a question. Unmute yourself, please.
Hi, Dr. Malik.
Hello.
I want to ask a question about if the nerve regenerates and heals itself, does it return to its previous state before the operation, or does it return to being a healthy nerve?
I mean, after the MVD, you mean?
Oh, anything really, any operation.
Well, if you, in MVD, you are not causing any damage to the nerve, at least you don't intend to, and therefore the nerve should remain the same. With the other procedures, let's say you do radiosurgery, a gamma knife, you're actually exposing the nerve to radiation. There would be a certain amount of damage to the nerve, and that probably would not recover. Here is the issue. The nerves outside of the brain and the spinal cord can regenerate. But within the spinal cord and the brain, they don't. There is a different lining. On the outside, the lining of the nerves is made of Schwann cells. And the lining on the inside is from the myelin. And that's the reason the pressure on the nerve from the blood vessel is what we refer to as nerve root entry zone. So for a certain segment, few millimeters after the nerve, before the nerve gets into the brainstem, that changes. And that's the area where the gamma knife radiosurgery is done. That's the area where the blood vessel is compressed. So that would not have the potential of regrowth. But if it was peripheral procedures, let's say you do radiofrequency, which is way outside, the nerve would have a tendency to recover itself. Obviously, most of it is theoretical because we don't open and look at the nerve either way. So,
thank you.
Dr. Malik, Renee has a question for you.
Sure.
I have had a failed MVD surgery 14 years ago, and the pain returned. And the recent MRI showed there was scar tissue around the Teflon pad. So what would be my next step?
Yeah, I have very much resisted to do second MVD for that particular reason, because there is definitely scarring there, and in order to take the scar tissue out, the nerve loses function. Patients get numbness. And if that is the end result, then you might as well do outside procedures, limited procedures, like radiofrequency rhizotomy or a gamma knife or balloon compression, those procedures that are going to give you benefit without the risk of having to go back in there and work on the nerve that has scar tissue.
Okay. Okay, thank you.
Other questions?
That's excellent, Dr. Malik. We really appreciate it.
Thank you so much, Dr. Malik.
It's always a pleasure.
Thank you
Thank
very
you,
much.
Dr. Malik.
Yeah, and I hear your son's a fabulous anesthesiologist.
Yes. Yes, he is.
That's so nice.
He takes care of both the adults and the children.
Oh, that's so nice.
After his papa.
That's
And
wonderful.
Your daughter's a neurologist, right?
Yeah, she is a stroke specialist.
Oh, a stroke specialist.
Yeah.
We'll try not
Wow.
to meet her too, but thank you so much.
You're
Thank
welcome.
you, thank you, thank
Yeah,
you.
thank you. Thank you,
All right.
doctor.
Yeah.
You guys take care, okay?
You too.
Thank you.
very much.
Thank you, Doctor. Did Tony ever get on, Pete?
Yes,
Is
yes. Yes, Tim, thank you.
Oh, you are? Okay.
Yep.
I didn't see you. Okay.
Right, well, I'm not putting, I saw me and that was enough.
You're hiding. Yeah.
I'm hiding, that's right.
Okay.
Thanks, Donna. That's Dr. Malik's nurse who
Fabulous.
Mary Ellen bragged about.
Fabulous, yes.
Well, he was a godsend. Thank you so much. I have numbness. I can live with that, but I'm like, again, 6 years out, almost 7 from the MVD. Sorry about the dog.
One of our youngest patients had the MVD done by Dr. Malik, and she's expecting her second baby. Is happily married and doing so well, and it's so nice. She was the young gal that had the bone that was cut away, and it's so nice to see her doing so well. You know, you go from 16 and not knowing what's going on, and then living a happy, normal life, and that's fabulous.
Such a dear, yeah.
Oh, they're such a good human. Yeah. Yep, he's a gem.
Mm-hmm.
Okay.
Thanks, Sam. I'll be leaving.
All right. Thanks, Alan.
Say hello to Susan. I
Thank
didn't
you,
say.
Lynn.
Yeah,